Hi, my name is Zach, and this slideshow is going to cover all the equipment that we covered in respiratory care tech and procedures with Lord James. On this slide, we're talking about standard and isolation PPE. PPE is used to prevent the transmission of infectious agents between patients and healthcare workers. There are no strict contraindications, but the type of PPE must match the isolation precautions such as contact, droplet, or airborne. PPE works by providing a physical barrier using gowns, gloves, masks, eye protection, and the outcomes we expect is reduced cross-contamination and fewer hospital-acquired infections. Standard PPE differs from isolation PPE in that isolation PPE is specific to the type of pathogen. Proper technique includes correct donning and doffing sequence and good hand hygiene. This slide covers oxygen cylinders. We use cylinders when a wall oxygen source isn't available. Contraindications include keeping them away from flames or grease because they're high pressure. Cylinders store compressed oxygen and use a regulator to control flow. We measure the remaining PSI and the flow rate. Common equipment includes E-tanks and H-tanks. Setting includes tank factors 0.28 for E-tanks and 3.14 for H-tanks. To calculate duration, use the formula PSI minus 500 times the tank factor divided by the flow. P-flow meters are used to monitor airway obstruction, especially in asthma. They shouldn't be used during severe respiratory distress. The device works by measuring peak expiratory flow when the patient blows out forcefully. The measurement is given in liters per minute. Technique includes taking a deep breath and blowing out fast and hard. Frequency is 2 to 3 attempts, and you record the best value. Ranges include the green zone, 50 to 80%, the yellow zone, 50 to 79%, and the red zone is less than 50% of the predicted. This slide is about arterial blood gas sampling. It's indicated when we need to evaluate ventilation, oxygenation, or acid-base status. Contraindications include poor circulation or patients with a high bleeding risk. ABGs work by drawing arterial blood with a heparinized syringe. Measurements include the pH, the PaCO2, the PaO2, and the bicarbonate. The full name is arterial blood gas. Technique includes performing the Allen test and inserting the needle at a 45-degree angle. Normal values include a pH of 7.35 to 7.45 and a PaCO2 of 35 to 45. And the bicarb is 22 to 26. A pulse oximeter is used to monitor oxygen saturation or SpO2. Contraindications include poor perfusion or wearing nail polish, which can affect accuracy. It works by shining light through tissue and measuring absorption. The outcome is a percentage saturation reading. Normal SpO2 is 95 to 100%, and abnormal is anything below 90. There are different types such as finger, ear, and forehead probes. A nasal cannula is used for patients with mild hypoxemia. It's not appropriate for patients who need high levels of oxygen. It works by delivering low-flow oxygen directly into the nose. Measurements include FiO2 between 24 and 44%. Flow range is 1 to 6 liters per minute. The percentage range increases about 4% per liter. A hazard is nasal dryness or irritation. An air entrainment mask, also known as a Venturi mask, is used when a patient needs precise FiO2, especially COPD patients. It's not ideal when humidification is needed. It works through jet entrainment, mixing room air with oxygen. The outcome is a very accurate FiO2. The formula is based on the air to oxygen ratio. Flow ranges vary from 24 to 50%. Patients with COPD benefit the most because it prevents over-oxygenation. Partial rebreather and non-rebreather masks are used for moderate to severe hypoxemia. They're contraindicated if the mask seal is poor. They work by using a reservoir bag to boost oxygen concentration. Outcomes include high FiO2 delivery. A partial rebreather delivers 40 to 70%, and a non-rebreather can reach 60 to 100%. Both require flows of at least 10 to 15 liters per minute. Simple and aerosol masks are used for humidity and aerosol medication. Patients who are claustrophobic may not tolerate these devices. They work by delivering oxygen or visible aerosol mist. Outcomes include improved humidity and medication delivery. Simple masks are low-flow devices, while aerosol masks provide humidified oxygen. Techniques include ensuring there is always visible mist. Patients benefit from these after extubation or surgery. High-flow nasal cannula is used for severe hypoxemia or post-extubation support. Contraindications include nasal obstruction. High-flow nasal cannula works by delivering heated, humidified oxygen up to 60 liters per minute. Outcomes include precise FiO2 from 21 to 100%. Hazards include gastric distension or discomfort. Settings include flow rates of 20 to 60 liters and adjustable FiO2. Patients with acute hypoxemic respiratory failure benefit the most. MDIs are used for delivering bronchodilators or steroids. Patients with poor coordination may struggle to use them. They work by releasing a pressurized meter dose of medication. Measurements include micrograms per puff. The full name is metered dose inhaler. Technique is to exhale, actuate the device, inhale slowly and deeply, and hold the breath for up to 10 seconds. Asthma and COPD patients benefit the most. A DPI is used to deliver medication without a propellant. It shouldn't be used in patients who have a low inspiratory flow. It works by using the patient's inhalation to disperse the medicated powder. Outcomes are based on inspiratory flow. The full name is dry powder inhaler. Technique is a fast, deep inhalation. Cooperative adult patients benefit the most. A small volume nebulizer delivers aerosolized medication. Contraindications include increased infection risk. It works by using gas flow to aerosolize liquid medication. Measurements include the flow of medication in ml per minute. Comparisons include continuous nebulizers versus breath-actuated types. Technique is slow, deep breathing. Patients with bronchospasm benefit from this therapy. Incentive spirometers help prevent atelectasis. They aren't appropriate for unconscious patients. They work by encouraging slow, deep inspirations to reach a volume goal. Outcomes include improved inspiratory volume. Instructions include sitting upright, inhaling slowly, and holding for 3 seconds. Technique is slow, deep inspiration. Recommended frequency is 10 breaths every hour while awake. IPPB is used when incentive spirometry isn't improving atelectasis. Contraindications include an untreated pneumothorax. IPPB works by providing positive pressure to expand the lungs. Outcomes include increased tidal volume. It benefits post-operative patients or those with muscle weakness. Settings include pressure, flow, and sensitivity. Increasing flow increases tidal volume, and increasing pressure increases overall expansion. Chest physiotherapy is for patients with retained secretions. Contraindications include rib fractures or unstable spinal injuries. It works through oscillation and percussion to loosen mucus. Outcomes include improved sputum clearance. Equipment includes vests, PEP devices, and manual percussion. Technique involves rhythmic percussion for 15 to 20 minutes. Patients with cystic fibrosis or bronchiectasis benefit the most. Suctioning removes retained secretions when patients can't clear them. Contraindications include severe hypoxemia or bradycardia. It works by applying negative pressure to remove mucus. Outcomes include improved breath sounds and oxygenation. Comparison: so oral suction is easier while nasotracheal is deeper and more invasive. Technique includes pre-oxygenating and limiting suction passes to under 15 seconds. Hazards include trauma, hypoxia, and arrhythmias. These airways maintain an open airway. OPAs shouldn't be used if a patient has a gag reflex, and MPAs shouldn't be used with facial trauma. They work by preventing obstruction from the tongue or bypassing nasal blockages. Outcomes include improved ventilation. OPAs go in the mouth while MPAs go in the nose. Technique includes inserting an OPA upside down and lubricating the MPA. Hazards include bleeding, vomiting, and laryngospasm. An endotracheal tube is used to protect the airway and allow ventilation. Contraindications include structural obstructions preventing insertion. It works by sealing the airway with an inflated cuff. Measurements include tidal volume delivery and cuff pressures of 20 to 30 centimeters of water. Technique involves placement with a laryngoscope. Hazards include dental trauma or tracheal injury. Patients in respiratory failure benefit the most. An ECG is used to monitor cardiac electrical activity. There are no major contraindications. It works by detecting electrical impulses through electrodes. Outcomes include heart rate and PQRST waveform analysis. The full name is electrocardiogram. Techniques include placing 10 electrodes in their proper positions. It benefits patients with arrhythmias or chest pain.